This talk will cover the administration of blood products and other therapies as it relates to people with disorders of the hematologic system. As a licensed practical nurse, you may or may not be involved in the administration of blood products. Most often, if you are, it will be in a situation where you're monitoring the administration, not necessarily initiating the administration of blood products. But this chart is a list of a lot of different blood products that you may be required to administer, and you really should be aware of and understand what they are and what they are used for. So packed red blood cells are red blood cells for which the plasma has been taken out of, so it's just cells, it's not whole blood. Whole blood is everything, but that provides a lot of fluid as well as cells, and sometimes what people really need is the cells and not the fluid. So that's what packed RBCs are, and this is used for severe anemia when there's blood loss. Frozen red blood cells is an autotransfusion, so that's when the cells are taken from the patient and saved for a future time, usually a surgical procedure that we know is going to require the use of blood. That saves the person from the possibility of a febrile transfusion reaction because they're being given their own blood, not blood from a donor. Washed red blood cells, this is when you have somebody who's got a history of a transfusion reaction or a bone marrow or stem cell transplant patient, and when they get the washed red blood cells, this takes the antibodies and anything that might provoke a reaction off of them. Platelets, you can get pooled platelets. Platelets are infused because people have a bleeding disorder. When you have thrombocytopenia, DIC, lots of different reasons that you would have a bleeding disorder. Pooled platelets are from multiple donors. Single platelet donors are for people who have a history of transfusion reactions, and those will be typed and crossed just like you would for red blood cells. Albumin. Albumin is a plasma protein, as you recall, and it has to do a lot with fluid balance. And so if you have hypovolemia and you need your volume expanded, you can give some albumin, and that will help pull fluid back into the vasculature. Fresh frozen plasma is exactly what it sounds like. It's the plasma minus the cells, and it's frozen. So what this does is, remember, plasma contains plasma proteins, and clotting factors are plasma proteins. And so this is very useful when you have somebody with a bleeding disorder who needs clotting factors. It's also occasionally used for volume replacement as well. Cryoprecipitate is a specific clotting factor. So if you have somebody with hemophilia and they need cryo, it's because that cryo contains the specific factor, clotting factor, that they're missing. And then white blood cells, they don't give these very often. Sometimes they'll give them for sepsis if you have a neutropenic infection that's unresponsive to antibiotics. But you don't see those transfused as often as you do some other things. This slide is exactly the same blood products as was in the previous slide, but what this tells you is the volume that is contained in the particular blood product you're infusing, and also what the infusion time is, how long it takes to infuse it or how long you can let it hang. I won't go through all of these. The one thing I will tell you is that there is a time limit on blood cells. So there's you obviously don't want to give them too fast, but you also don't want to let them hang too long. And so if they're not in within a certain time, you have to discard them. The other thing is that albumin going down, you can dilute the albumin in normal saline to give it more volume and give it over a longer period of time. This slide shows you examples of what blood bags or bottles of blood products looks like. So up in the upper left, you have packed red blood cells with different types. So you've got A positive and B positive there. Right next to it, there on the top, is fresh frozen plasma. Going around clockwise to the bottom, you have cryoprecipitate, which looks like plasma because it is plasma proteins. Then moving around to the center, albumin comes in a little bottle. And as I mentioned earlier, can be diluted or given undiluted, just depends on the person and what is ordered and what the needs are. And then finally, in the lower left-hand corner, you have a bag of platelets, pooled platelets. Again, these look like plasma, but it is a bag of pooled donor platelets here. The administration of blood products requires informed consent, and so the person receiving the blood products needs to have a signed consent form. If the person who is to receive them is not able to sign and the condition is life-threatening, say for instance if you have trauma or uncontrolled bleeding with DIC or whatever, you have no family member present, the provider may make that decision to transfuse the patient without consent. Depending where you practice, because remember, nursing falls under the auspices of the state government, and so there's no across-the-board national policy on this. Nurse Practice Acts vary state to state. So wherever you practice, make sure you check what the role in administration of blood products is for LPNs. In Washington, there's nothing in the WACs specifically, but there's an advisory opinion that states that it can be done under the direct supervision of an RN with documented annual education. So what this advisory opinion says is that licensed practical nurses may, under the supervision of a registered nurse, administer intravenous medications and fluids, provided the LPN has had the appropriate practice and annual documented education. And then it also says blood or blood products shall only be given with direct supervision. And the WAC there is 24684001022A. You won't be tested on that. But the point is you need to have direct supervision. It needs to be part of the facility policy, and they need to do documented annual training and competency review. Some points that you want to consider when you're talking about older adults. Vessels are very fragile in older adults, and normally when you want to infuse a blood product, You think about using an 18 gauge cannula because you don't want those products to hemolyze, having to go through a very narrow gauge opening. However, if you've got somebody who's got fragile vasculature, you might want to go down even to a 22 to make sure that you're not damaging their vessels. Blood products should also be transfused more slowly to an older adult to allow their body time to adjust to the added volume, because remember, they don't deal with changes in volume as easily as does a younger person. Following up there, you want careful assessment for fluid overload during and after the transfusion. And then, of course, signs of fluid overload are the rapid bionic pulse, hypertension, swollen veins, perhaps crackles. Very important to think about fluid volumes when you're giving any IV to older adults. Anytime you administer any type of medication, it's important to do your rights and cross-check the identifiers. But it's especially important with transfusion, because transfusion errors can lead to life-threatening reactions, and it can happen very quickly because you're putting it directly into someone's vein. So if you look at a blood product, there will always be an order, and then make sure that they're getting what's ordered. So if they want washed red blood cells, for instance, make sure that those cells have indeed been washed. You want to match the patient to the blood component. So you're looking at, was this ordered for this specific patient? Because quite often they will be type and cross match or HLA matched, and you want to make sure that the particular product matches the patient it was intended for. You always use two-person verification process, or if there's only one person available, there needs to be an automated ID or a barcode. This is Joint Commission recommendations for the safe administration of blood products. It's one of the National Patient Safety Goals. Two-person identification. One person will be responsible for administering the blood product. So it's not like the unit secretary and the blood bank can do this on their own and then hand it to you. If you're the person administering it, you need to be one of the people, one of those two people doing the identification. And the second person required needs to be qualified to participate in the product per policy. So quite often the lab people, of course, will be qualified to do this. Sometimes the nursing assistant or the unit secretary will be. Sometimes you have to get another nurse. So it just really depends on what your facility policy is, and that's something very important for you to know in order for you to A, be able to do it safely, and B, for it to be defensible in court should that come up. Besides the precautions that you need to take with identification of the blood products and matching them specifically to the patient designated to receive them, you also need to think about some other things, one of which is fluid compatibility. You only use normal saline. Again, you only use normal saline when you are infusing blood products. Timing is important here. Each unit of packed red blood cells should be infused over about 2 hours. You can infuse it a little bit more quickly if the person really needs it. They have what they call rapid infusers, but it shouldn't hang any more than 4 hours because the cells will start to deteriorate. Filtering and special tubing. So there is special tubing that you use to infuse blood products depending on what you're infusing, and there are filters that are on the blood tubing. So that's really important. If you are giving washed or leukocyte depleted blood, they will be in a special round bag. So you probably have in your head the visual of the normal rectangular shaped blood bag, but when you've got washed cells, they will put them in a special round bag, and that's a good check to know that you've got the right kind of cells, to know that the plasma's been removed, and this will decrease the chance of a febrile reaction. They also can use special leukocyte filters with this, just in case any cells remain. You can give warmed blood in cases of severe bleeding when you have multiple rapid transfusions. This can prevent the hypothermia that you give, because most of the blood cells are delivered cold because they're kept refrigerated. And this can also prevent other problems such as dysrhythmias and shivering. And especially shivering can destroy blood products, and that's a real problem. And so warmed blood is something that you can do. If you haven't gotten the picture that there's a lot of one-on-one nursing care that goes into administering blood by now, this slide should hammer it home for you. So you need to stay with the person you are administering this blood product to for 15 minutes. You need to get vital signs before the infusion, and this includes temperature, because febrile reaction is one of the big things you need to look for here. So vital signs including temperature prior to the infusion, and then every 15 to 30 minutes early on, whatever your policy is. Less often during the later part of the infusion, but again, according to what your policy is. And then again, after the transfusion, according to your policy. But in that first 15 minutes is when you'll often see the first signs of the transfusion reaction, and that begins when the blood enters the vein, and that's when you want to start to assess for complications and be able to treat them quickly. That's why you need to stay there. So now we're going to talk about transfusion reactions, and the most common kind of transfusion reaction, as I mentioned in the last slide, is a febrile transfusion reaction. It's about 2% of all transfusions will get a febrile reaction. So one thing that you can do is make sure the blood never hangs over 4 hours, because then the blood cells deteriorate, and that increases the chance of a reaction. The other thing that you need to know is that the risk increases with each unit of blood the patient receives. So if you've got somebody who's actively bleeding or has a trauma and who's lost a lot of blood, the risk goes up with every unit you hang. Sometimes this can even occur post-transfusion. So remember, usually I said you'll start to see something in the first 15 minutes, but not always. And so you need to continue to be vigilant post-transfusion. If they become symptomatic during the transfusion, you stop the transfusion and notify the provider immediately. And the symptoms that you're looking for here are fever, chills, and these chills can be severe. I have seen people just shake so violently with this. They'll also get a headache, which is often the first sign that they'll complain of a headache before you even take their vitals, and they'll also get some back pain. Sometimes, if you have a febrile reaction, they might continue the transfusion if they suspect that there's no hemolytic reaction going on and the person really needs the blood. And again, if a person has had a febrile reaction previously, they will usually try to give them leukocyte depleted blood, and that can help prevent this. Urticaria or hives are considered a minor allergic reaction. It's associated with the antigens in the plasma, and so if the symptoms occur, you for sure want to stop the transfusion and notify the provider. But often what they'll do is they'll treat with an antihistamine. So they'll give something like diphenhydramine or Benadryl and then continue with the transfusion. And so you just need to talk to the provider and figure out what the course of action is going to be. The symptoms here are urticaria, so hives, which are raised red confluent rash. And you can also get a little bit of fever with this as well. So the most serious transfusion reaction you can get is hemolytic transfusion reaction. This is the most deadly, and the good news is it's also the rarest reaction that you'll see. It is caused by an ABO or RH incompatibility, and this causes hemolysis, the destruction of the blood cells. It happens within minutes of the initiation of the transfusion. It happens very, very quickly. And so what you want to do is immediately stop the transfusion, stay with the patient, notify the provider, and institute emergency procedures. The other thing you need to do is notify the blood bank, because there may well have been some mistake in cross-matching the blood. And even if there wasn't a mistake, they need to know this, because if more blood products are ordered for this patient, the blood bank needs to be aware of this. Symptoms that you might see with a hemolytic reaction are back pain, chest pain, chills, fever, dyspnea, nausea and vomiting, that feeling of impending doom, just that something horrible is going to happen. As you can see here, There are some of the same symptoms that you would see maybe in a febrile reaction, but these are much more serious and they happen much more quickly. And as this progresses, if it's allowed to progress, you'll see classic signs of shock. So you'll get hypotension, oliguria, decreased level of consciousness, and sometimes later on, DIC, disseminated intravascular coagulation, will happen, and it can be fatal. So how do you treat this? Well, you get brand new tubing, discontinue the infusion, get brand new tubing, and start to keep open normal saline. So TKO or KVO is probably about 15 to 30 mils an hour. Just make sure you've got access is what you're doing here. And then after you get that started, then depending on your orders, you'll probably get a high volume of fluids to infuse, diuretics, and sometimes they will even dialyze somebody. Another rare but very dangerous reaction that you will see sometimes is an anaphylactic reaction. It's seen in people who usually have had multiple transfusions or multiple pregnancies. Why multiple pregnancies? Well, because your baby may have a different blood type, and that those antibodies may mix and cross the placenta. So usually people who've been sensitized with the transfusions or the pregnancies are the people that you see this with because of the immunoglobulins present in the donor blood product. So again, stop the infusion, stay with the patient, and call the rapid response or the code team, whatever happens in your particular facility. And the interesting thing about this is the very first milliliter of blood that infuses into those veins may cause the development of respiratory or cardiovascular collapse. So, you know, when I say you have to stay there for 15 minutes, you have to stay there and watch like a hawk for 15 minutes. The other symptoms that can happen are severe GI cramping, really just instant vomiting, uncontrollable diarrhea. It's a very, very bad reaction, and there will be no doubt in your mind what's going on here. In that early slide, we talked about the volume of fluid that is in certain blood products. And if you have rapid transfusion of multiple blood products over a short period of time, there is a danger of circulatory overload in antibody. But especially in older adults or people with heart disease or less renal ability to take care of or manage that fluid. The symptoms, of course, would be chest pain, pink frothy sputum because of the pulmonary edema, distended neck veins, increased heart rate. So you want to monitor lung sounds and vital signs. Think about new onset of crackles and dyspnea, a hypertension or a bounding pulse. Any of these things should be reported immediately. So of course you're going to notify the provider. The transfusion can continue, but you want to think about diuretics and maybe slowing the transfusion down to give the circulatory system the chance to handle the increased volume. Some other therapies for hematologic conditions that you should be aware of. One of them is leukapheresis. So what this is it's a direct connection to basically a blood separator machine. The blood is drained out a little at a time. The white cells are washed out and the red cells in the plasma are returned. And what this does is it clears the excessive white blood cells from the blood if indeed you have a lot of leukemia cells in your blood. It's used to treat chronic myelogenous leukemia, CML, and other immune disorders. Then the other thing you need to think about, because you will be administering these, are colony stimulating factors. What these do is these stimulate the bone marrow to produce more cells. This is made with recombinant DNA, and it's pretty amazing, actually. I remember a time when these weren't available, and this has been life-changing, literally life-changing, for people who have these hematologic disorders or who undergo chemotherapy and their counts are low. They are surviving now where they weren't before. So one that you're probably the most familiar with is erythropoietin or epogen, which, as the name sounds, is for red blood cell stimulation. Granulocyte colony stimulating factor, filgrastim, Neulasta, Neupogen. These are drugs that stimulate the production of white blood cells. And then granulocyte macrophage colony stimulating factor. It's exactly what it sounds like. It stimulates granulocytes and macrophages, so it stimulates white blood cells. And then RHTPN, which is recombinant human thrombopoietin, and that stimulates the production of platelets. Other therapies that you should be aware of are bone marrow or stem cell transplants. Bone marrow transplant provides healthy marrow when the patient's bone marrow is faulty because of a disease or has been destroyed by chemo or radiation. You can take autologous stem cells when the patient is in remission and then reinfuse those, and so that's an autologous transplant. You get your own cells, or there's an allogenic transplant when you get them from somebody else who is an HLA match. A stem cell transplant is when you take peripheral stem cells from umbilical cord blood or autologous stem cells from the person and then reinfuse those. So what happens is the bone marrow or the stem cells are matched by HLA tissue typing. There's a 25% chance of matching with a sibling. That's really not very high, but sometimes it's the best chance you've got. And then what they do is, if they're going to harvest bone marrow, this is done in the OR, and they do multiple aspirations of bone marrow from all those places that we learned in the anatomy and physiology slides that bone marrow lives. So the flat bones, the epiphyses of the long bones, and this is done most often in the iliac crest, and you can get 500 to 1,000 mils out of there, but it takes multiple aspirations to do that. Then the bone marrow is filtered and it's purged to get rid of cancer cells if it's an autologous transplant, or T cells if it's an allogenic transplant, because remember, your body can react to the T cells. Then an autologous transplant, or excuse me, aspiration is frozen because it's the patient's own blood and they're not quite ready, or excuse me, bone marrow, and they're not quite ready to get that yet. So that'll be frozen and saved for when they're ready to get that. And allogenic aspirate will be transfused immediately. The nursing care after you harvest, of course, would be monitoring the dressings for bleeding and pain control. I have not ever taken care of anybody who's had aspiration, but I understand that it can be very painful. So then if you think about, we talked about the donor in the previous slide. So if you think about the recipient, what happens then is they go through a regimen of chemotherapy and radiation to rid body of not only the cancer cells and the diseased marrow, but basically to just totally kill off their bone marrow. And this can take anywhere from 5 to 10 days. And the side effects are severe because you are totally destroying their ability to produce cells to protect themselves from infection and from bleeding. So this takes meticulous, supportive, and preventative nursing care. They get pancytopenia, which means all of their cells are decreased. There can be stomatitis, nausea and vomiting, extreme risk for infection, extreme risk for bleeding. And so they're always in protective isolation, and you have to be really careful when you move them, touch them. You don't want to, you want to limit the sticks for blood draws or injections or anything like that. So once they've determined that the bone marrow has been depleted, then the transplant is usually a couple of days after the end of the chemo. And it basically just is infused through a central line over about 30 minutes, just like an IV piggyback antibiotic. So that is the least dramatic part of the whole process. So then after that, you have hopefully engraftment. So in about 2 to 5 weeks, you will see the bone marrow that was transfused and engrafted start to produce cells. And that's when the counts should begin to rise. And remember, this person is in protective isolation the whole time because they're still pancytopenic. High risk of infection, high risk of bleeding during this time. And then once you get engraftment and cell protection or production happening, then what happens is you can get a complication called graft versus host disease, which is when the graft, which is the new bone marrow, sees the patient's tissues or the host cells as foreign. And so then it will mount an immune attack on the patient's own tissues. And this can be different tissues of the body. Quite often it's in the gut. And then you have to treat that with supportive treatment and immunosuppression. And that can become a serious thing. Finally, some cultural considerations with bone marrow. So there is a bone marrow registry, and it is composed of people who have had their blood HLA type. So HLA stands for human leukocyte antigen, and that, I can't remember, it's either 10 or 12 factors that are involved in a match for HLA. And so what happens is people who are willing to donate give blood, they have their blood typed, and then they belong to a registry. And so then if someone else needs a transplant, they look to that registry and try to find a match for the patient's HLA type and the donor's HLA type. That donor gets a call, and then that donor is asked to go in and donate bone marrow. So most of the people willing to donate bone marrow in our country right now are white. There is a 30 to 40% chance of an HLA match for a white patient and donor marrow. For whatever reason, far fewer people of color, African Americans here, but I'm just going to say in general, people of color have signed up at the bone marrow registry. And so the chance for an HLA match for an African American or other person of color is less than 20%. So what we need to do as healthcare providers is get the word out and try to encourage people of color in our society to sign up for the registry so that their marrow will be available to match with people who need it. It's really important, and it's probably rare that you would be tapped, no pun intended there, to give your bone marrow if you register. But if you do register and you do become a donor, you are literally saving someone's life, and that's a big deal. So I think it's important for us to get out there and do some public education on this.